Okay, good morning. So this will be the continuation. Okay, so just to review from yesterday. So we have an algorithm, right? So from screening to diagnosis and treatment. Today will be the treatment part of it. Okay, so just to review. So the step one of the algorithm is to screen. So anything more than 10. And you can actually customize this. If you want it 8, it's good too. So, and then step two. Step two is to ask for any comorbidities, okay, health risks. So if you have these comorbidities, highly suspect that you might be suffering from OSA. And look for risk factors. If you have some of these, you might be you might suspect that you might be suffering from that OSA. Then signs and symptoms of it. Okay, loud snoring, gasping, witness apnea, clenching and grinding, morning headaches, sleepiness. So once you have all this, suspect OSA strongly. So the next part will be, so after all this, is sleep study test. Okay, so when we to do the sleep study test, it's very important because this is where the diagnosis part is. So like I mentioned, dentists cannot prescribe yet. Okay, so we have to refer to sleep doctors, and the sleep doctors will be the one to prescribe PSG. Okay, so the next steps for today that we'll be discussing is the next 5 steps. So ENT consult is very important. And then we find out if CPAP is a good option for them, if they can tolerate it. If not, what other options can we consider? These are all what dentists can do. We can ask for a surgery, or we can do mandibular advancement device and all those things. So we'll start with this. And today we'll do this. Okay, so just to go over, so this is what we did yesterday. Anything, if your score is anything between 11 and 15, it suggests that you have a mild to moderate. 16 and over, suspect narcolepsy or severe OSA. And anything more than 10 has to be evaluated. And like I said, if you have this score, you might be okay. Right? So as for any health consequences, this is just a review. As for risk factors, signs and symptoms, if you have all this, suspect OSA. And then you do the PSG. Okay. So to be diagnosed with OSA, you'll need to undergo a sleep study, also known as polysomnography, which most of you know. So we went to this place. So this is like a sleep study test place. Okay, so I was amazed that this facility actually has, it's like a hotel room. Where is it? Can you? Okay. So from what I've heard, this is the only place right now that has this facility in Vietnam. I don't know if it's Ho Chi Minh. Okay, so and this is like a hotel, right? So they have all this, they have TVs. We were there. Okay, so we just kind of check out the place. We're curious what they have and what they offer. So this is the group, and we saw everyone here, the staff. So we were all impressed by the staff, the facility, and what's most impressive is the food that they serve. Okay, so I've never seen such a big, like a giant gourami, you know? So they call it elephant ear fish or something. But what I could probably recommend is probably after all this is to have a massage. Can you play that? Like this. So that would probably be a good addition, you know? Okay. All right. So step 6 now, ENT consult. We'll start with number 6. So the goal for ENT consult is to make sure that you can breathe through the nose. So in orthodontics and in dentistry, we are big on breathing through the nose. And for us, none of the therapy will work if ultimately you're not breathing through the nose. It's very important that the mouth is closed, because when the mouth is closed, the tongue is actually positioned against the roof of the mouth. And if the mouth is open, the tongue can actually relax towards the airway. So this is we are very strong proponent of nasal breathing. So in any treatment that we do, we have to make sure that the patient can breathe through the nose. That's number 1 for us. So we always go to the do some ENT consult, make sure there's no deviated septum, there's no enlarged turbinates, nasal polyps. It has to, or if you had allergies from the past, those needs to be controlled or taken. You should be taking some medications for it. Because whatever we do from there, and the patients are not ultimately breathing through the nose, whether you do CPAP, you do other treatment, Inspire, it's still not going to work ultimately, because the tongue definitely needs to be, because the tongue is the biggest obstructor. That's the biggest offense. It's the tongue. That's the one that obstructs our airway. So it's important that we have to switch our patients from mouth breathing to nasal breathing. Okay. Then next step is the patient, if the patient is recommended to wear CPAP, okay? So we have to ask, is the patient, can the patient tolerate the CPAP? Okay, so it's still the gold standard. And we are with that. No, we don't oppose it. If you can wear CPAP, the best. Okay, but some patients cannot tolerate it. Okay, so if the patient cannot tolerate that, then we should have other options for them. Like Kem said, it's still like minimum 50% compliance rate for CPAP, although it works. It's just that the thought of wearing this every night, it kind of scares the patients. Like, oh, okay, it works, but I have to wear this overnight, and then I have to worry about the fit and all those stuff. Okay, so if this works, then we're done with the step. We go now to step 10, which we reassess. Because like I said, some patients will respond very well, and then all of a sudden something happened, right? Probably patient gained weight, or developed some mouth breathing again, or some nasal obstruction or allergies. Then we have to reassess again. Okay. So CPAP is still the most efficacious treatment for OSA. Okay, so there's no doubt about that. But the problem is there is really low compliance and acceptance, which makes it not for everybody. Okay, so not a lot of treatments are for everyone anyway. So CPAP is actually one of them. Okay, so what if they're not for CPAP? Next question we ask is, what about surgery? So we ask yes or no. So when we do surgery, so now this is oral maxillofacial surgeon that we work with. Okay, so this is dental person. We collaborate with doctors, but now with the treatment, this is more like in our turf. Okay, so this is more dental. So if you say yes, probably let's consider a surgery. Then when do we do the surgery? So one of the risk factors is retrognathia, right? Poor jaw development, right? So the lower jaw. So if you have mandibular deficiency, can you play that? Oh, we go back. Let's go back. Go back, yeah. Oop. Okay, then just play that one. Okay, so this is just, it's like a bilateral sagittal split. So it's like you're moving your bottom jaw forward. So this is the surgical part of it. Like I said, when you move the jaw forward, now you have more space for your tongue. Okay, so for mandibular deficiency, mandibular advancement surgery is recommended. Now, what if you have maxillary deficiency? So these are the stuff that we see also. Should we do maxillary advancement in this situation? What if it's both maxillomandibular? So maxillomandibular advancement is actually very popular. Okay, so that's mostly what is recommended. It really increases the airway size from the velopharyngeal, which is behind the soft palate, and the retroglossal area behind the tongue. So this is actually pretty good. Okay, so this is the part that when we recommend or refer. So we are on standby. Sleep dentists are on standby. So we go for CPAP. Then what about surgery? Okay, so if we satisfy, well, okay, so this patient would definitely benefit from surgery, then we go for that. Okay, but what if it doesn't need a surgery? So when do we do other treatments aside from CPAP and surgery? So this is where we come in. If it's no surgery, then we have two areas that we can help the patient. It's called expansion orthodontics or mandibular advancement device. Now we're going to have to choose which one is going to be better for them. So mandibular advancement device is the leading alternative to CPAP. Okay, so I wear one for myself. They are very efficient and effective for mild, but they can also be used for mild, moderate, and severe. Okay, so, and I'll show you a study that was just released this year. They did a meta-analysis. So the health impact of mandibular advancement device on OSA patients is comparable to PAP treatments. Okay, so if we have that, this is just to let you know that, hey, there's another option for this. Okay, so if some patients don't want to wear CPAP, then we have this. This is really more portable, right? You don't have to bring, but PAP machines are small now, so it's not as much of an issue as before. So, and it only requires at least 8 teeth in each arch. Okay, most patients who snore, sometimes they don't have that much teeth because of problems with gum issues, periodontal disease, because they breathe through their mouth, right? So here we just need 8 teeth for each arch, and make sure there's no advanced periodontal issues. Okay, so no issues. And test if you can move the jaw forward as far as 5 millimeters at least. You can move the jaw forward. Then that might be, because if you can't really move forward, so you might want to consider something else. So these are the options. Okay, so this is how it looks. So basically what it does is, anyway, so this is compliance sensor anyway. So now we have this. So the patient now can look at things and say and be more proactive with their treatment, because now they can see how much they use it, and then they can correlate that to their how they feel during the day, and after they sleep, are they energized, and all those things. So basically, this is what happens, right? So there's obstructions, the air can't go in, but the moment you wear an appliance and move the jaw forward, you actually have enough space and you can breathe better. So like I said, again, this is for mild to moderate, but we can also use it in severe. Okay, so I don't know if this works. Oh, there you go. So there's not that much space right here. And then you create that space for the air to come in. Okay. So what's the specific indications for MAD? Ideal for those who struggle with CPAP. So next thing, if the patient can't wear CPAP, consider actually, okay, so probably talk to your doctor, because we can't do a mandibular advancement device until it's prescribed by the sleep doctor. Okay, then we'll do it. And it's very effective for mild to moderate. If you only have mild to moderate, this might be the best option for you. Okay. But if you have severe OSA and you cannot tolerate it, treatment option when compliance is problematic, mandibular advancement device is good for you, even if it's severe. Okay, so but we have to talk about efficacy and efficiency. Efficacy is how well a treatment works under ideal conditions. Efficiency is how effectively a treatment achieves results using at least minimum amount of resources. So for CPAP, it is highly effective in reducing AHI. Okay, is it efficient? Not as much, because the patient has to wear it every night, and compliance is the problem. If the patient is comfortable with wearing CPAP, this is the best. Okay, no doubt. With mandibular advancement device, it is effective for mild to moderate OSA, okay, by moving the jaw forward to keep the airway open. But it's most efficient, more efficient than the CPAP, because it's easy, it's comfortable, and it's easy to wear, right? There's no other appliance. You just put it in, there's no air, no nothing. It's just that. Okay, so that's why if in CPAP is highly efficient, but if patient doesn't wear it or use it, then it's really not helping them. MAD is not highly efficient, but if the patient is wearing it, then at least it's good enough. Okay, so a study in February 2024, and they did a meta-analysis this year only. They found out that they are effective also for moderate and severe OSA. Before, we're just like, tethering towards severe, but it's because it's only good for mild to moderate. Now they're being bold in saying, hey, we can actually do this even with severe OSA. Okay, but again, it's perfect for mild, okay, mild OSA. And they found out that it actually also, it helps improve sleepiness, ODI, and your low oxyhemoglobin saturation. So across mild, moderate, and severe. So this is this year, okay? So that's good. That's good for us. That's good for the sleep community, that we have options now, okay? Okay, so but every time we tell the patients, hey, this is a good option for you, but there are some side effects or disadvantages. At first, you will really drool. There's so much saliva there because your brain thinks it's food. So the more you wear it, the more the brain is going to get used to it. No, it's not food. Okay, so you're not going to salivate anymore. There would be some TMJ issues, but sometimes if you have TMJ issues, it actually helps it. Okay, and there might be some changes in your bite. So the first thing that we tell the patient is your bite might change. Right away, we have to tell them that. Not everyone though, but the number one side effect of mandibular advancement device is actually your bite will change. Okay, so but if you were to choose, You want to sleep better, feel better? Or you want to look good? If you can do both, that's good, because it's really not going to damage your teeth. It's just the way the bite come together. So what other options do we have aside from mandibular advancement device? Orthodontics. So orthodontics, we call it airway and sleep orthodontics. So we call it expansion. So when do we need to do this? Okay, so when you see something like this, okay, I want you to look at this. This is expansion orthodontics. It doesn't matter how old you are. Before, we can only expand until 15 years old. But now even older patients, we can actually break the maxilla and split it open. Okay, so in this case, when you see something like this, it's a crowded mouth, it's a crowded airway. Okay, so when you see a lot of malocclusion or crowding, that tells you right away that the tongue is not at the roof of the mouth. The tongue is what is your natural expander, okay? Your cheeks and your lips are your natural braces. If your tongue is up in the roof of the mouth and it's counterbalanced by your cheek and your lips, imagine you're growing when you were young and you have that, you won't need orthodontics. So why do you have this situation? Because there's an even balance. The tongue is not up there, so there's more influence of the cheek and the lips. So if there's more influence of the cheeks, nothing counteracting the opposite side, which is the tongue side, it will actually crowd, right? So whenever you see something like this, oh, okay, so the tongue was never up there. So that's one of the risk factors also. Now, if you see something like this, there's a lot in orthodontics. What do they do to relieve the crowding? They pull for teeth, right? Now, as an orthodontist, me, myself, I kind of geared away from that, especially if there are risk factors, there's signs and symptoms and comorbidities. I'm not going to pull teeth here. Because the moment I pull teeth here, what's going to happen? The tongue won't have any more space, right? So it's kind of like that. It's like you have a very tight, your tongue, you will have those indentations because it won't fit up in the roof of the mouth, right? So that's the very first sign. So if you come to an orthodontist and they do traditional treatment, and what is that? We're going to go ahead and pull some teeth, and you're going to have a nice, well-aligned teeth. But actually, we are subjecting the patients to much more problem in the future. And that is why there are relapse. And if you notice, most orthodontists, they use fixed lingual retainers where they cement at the bottom because it will relapse because there's no balance between the tongue, which is the inside force, and the cheek and the lips, which is the outside force. There should always be that. So myofunctional therapy, I don't know if you've heard of that, is part of our therapy for patients like this. So in cases like this, what do we do? How do you fix this? Okay, can you play that one? So we Okay, so the agenda is to open it up, create more space. Remember that arch is collapsed. That the goal really is, when you do orthodontics nowadays, is to really make room for the tongue. Okay, now Then after that, after we do it, we start the expansion 5 opening, right? It's like 0.2 millimeters. So it's like 5 rotation is like 1 millimeter. 1 millimeter only. And then 1 every day. So 0.2 millimeter. And it will break the mid-palatal suture. There's a suture there that you can expand. Okay. Now, this is not me. This is an oral surgeon. Okay, so for the bottom, there's no suture. Right? There's no suture. You can't really expand at the bottom. A lot of people will say, hey, we're going to expand at the bottom arches. You cannot expand. You have to split that mandible. And that's what we did. So we call it mandibular midline distraction osteogenesis. So that's the nose. So go ahead and play it. Create a cut there, right? So we're starting with that. There's already a cut just to kind of like open it up a little bit, okay? So now we're splitting here, the jaw, right? We're not expanding because there's no suture, but we still have an expander. So meaning once it splits, we start expanding it. It's open, okay? So this is before and after. So from a very, very crowded, and this is how I finished this case. This is not painful at all, except this. But the recovery is very quick. These are all the bottom one, the MMDO is done GA. Okay. So, but the top one, you don't have to. But once we have that already in place, the reason why we're doing this, it's because now the orthodontics should really start accommodating the tongue. The tongue is your biggest obstructor. So if you don't accommodate that tongue, it will go in the airway. So what we're doing now, orthodontics should go towards that. We have to expand arches and not pull teeth, because when you pull teeth, it will just make it even shorter and narrower. So imagine if I didn't expand that and I pulled some teeth, I will be able to align it. But orthodontics should not be just aligning teeth, because like I said, you have to suspect crowded teeth is a crowded airway. So right away, you would know, hey, if there is some mild undiagnosed sleep disorder breathing here, we are actually setting them up to fail in the future. So this will be now the text. Try to see and check if they have all their premolars. A lot of their patients probably don't have those premolars, and they have small, or probably they have crowded teeth. Okay, so start looking at those now and it will make sense to you. So that's why nowadays we don't pull teeth, just to align. Okay, so we will expand, accommodate all teeth, make the arch big to accommodate the tongue. And after all this, next step is reassess. Okay, next step, reassess. Reassess response within 3 to 6 or 12 months. Okay, so we are successful. The symptoms got better, AHI got reduced. You still need to reassess. In our case, we need to see the patients every 3, 6, and 12 months, just to make sure patient is compliant, symptoms are under control, and they wake up re-energized. So again, I always give this as a quote to everybody. Consider this. Ultimately, you have to breathe through your nose. And if you're not, none of what you do really matters. Somebody mentioned about leptin and ghrelin, right? So if I am doing diet and exercise, that diet's not going to work. It will work, but not really. It's almost like Ozempic. It will work, and then eventually you're going to regain it back. So when you are on a fight or flight, or you have OSA, your leptin doesn't work. That gives you like I think Dr. Trish was the one who mentioned it, that it's a satiety hormone, right? So it tells you when you're full. And ghrelin is there's Dr. Trish. She was mentioning about that leptin. And ghrelin is a hormone that tells you when you're hungry. So that's why when patients with OSA, okay, there's cannabinoid effect on that. It's almost like, how come I never get full? And how come I'm always hungry? Because those two hormones don't work. Okay, so imagine leptin. Leptin tells you you're full. If you're driving a car with your fuel gauge not working, okay, your fuel gauge is not working. So you travel from Ho Chi Minh to Halong Bay, and your fuel gauge doesn't work. So what are you gonna do? So every time you see a fuel, you will stop, right? And you're gonna fuel. Because you'll never know if you're gonna run out of fuel. Same thing when you are suffering from leptin. It affects your hormones like leptin. People will tend to eat every once in a while because the brain thinks you're not full. So it's like traveling from, like I said, Ho Chi Minh City to Halong Bay, and you're gonna have to keep eating, or you have to keep putting fuel just to make sure that you have it, right? So there's a lot of things that happen on that. So if your patient, for us, and I always tell this to everybody, my colleague, is not ultimately breathing through the nose, none of your therapy matters. Remember, all this started because we can't breathe through our nose. Do you really think if you can breathe through your nose, you're going to have crowded airway? You're going to have issues with breathing during sleep? If you are breathing through the nose. The only reason why you started having those issues is because now the tongue don't have any spot but the airway. If your mouth is closed, it's in the roof of your mouth. And if you're growing, if your kids are like that, if you see your kids sleeping with their mouth open, you have to close it. And if there's issue with allergies or adenoids or tonsils, go to ENT. Resolve those issues. That's the first thing. Symptoms for kids who suffer from sleep disorder breathing is ADHD. In our community, we suspect first SDB before ADHD. And the reason why kids don't have attention is, we call it attention shifting. It's because when I talk to them, right? If I talk to them and they shift their attention, it's not because they're trying to be disrespectful, but it's because if I keep listening to you, I'm going to fall asleep. And the reason why they're hyperactive, they bounce off the wall, because if they sit in one place, they're going to fall asleep. So those symptoms, hyperactivity and inattention, is their attempt to keep themselves alert and awake. So it's a different manifestations for women, for men, and for kids. So we have to know all those. So remember that. So if you have kids diagnosed with ADHD and they're trying to give you medications, why don't you do the screening first? The screening, it's not Epworth because it's different for kids, but you still follow what are the risks, is there comorbidities, what are the signs and symptoms. If they've been diagnosed with ADHD, go through that, and if it needs a sleep study test, let's do that. Okay. So if OSA improves, monitor clinically and reevaluate in 3 to 6 and 12 months. Things change. We gain weight. Okay, so a lot of times Patient will say, hey, how come last night I've been doing really well? And then my husband or my wife told me that I snore. Sometimes you just have to ask, did you drink alcohol that night? You know, sometimes there are just changes like that. Doesn't mean it doesn't work. It's just that it's more challenging now because, muscles tend to relax more. Okay, so if OSA is still clinical significant, offer alternate therapy. So what I'm trying to say is, if I do orthodontics, my retainers probably would be mandibular advancement device. Okay, so now you can, or I might have to consider surgery now, right? If it's still there, right? Or we might revisit CPAP again. So it cannot be just one treatment. And that's the reason why the way I presented this is really collaboration. It's not just us dentists will treat this. We really respect this medical community. The medical community is the first for us. Hey, we suspect something here. Go ahead and do an ENT consult. Go ahead and look at your sleep doctors. Go ahead and look at your internist. How come you have type 2 diabetes? Let's try to see what's going on there. Then before you come in, I already know what's going on. Then I would know how to effectively treat the patient. This is not just, hey, a patient come in, hey, let's do a mandibular advancement device. No, it's not. That's not how we do it there. Okay. So in summary, we already know this, like the last time, I think they did this as a summary also. So there's really a lot of us that suffers from this. And it doesn't really get better. It actually gets worse, right? So it's not like, that's the reason why I want you to reassess this, because as we age, the worse we get, right? We gain weight, our muscles become more limp, right? That's why we have to exercise, right? And that's why there's myofunctional therapy, because you need to exercise your tongue also. When you gain weight, fat is right away distributed in the tongue, and the tongue actually gets fat. So that's the reason why you need to consider the tongue always. Okay. Now, if you're frequently feeling excessively sleeping during the day, you have the signs and symptoms. This is what we did, and have risk factors dealing with cardiovascular diseases. There's a chance that you might have undiagnosed or even untreated obstructive sleep apnea. Okay, so we went through all those stuff. Okay, dentists. So I know Dr. Fong is a dentist. We really play a big role in this, and somehow dentists are the captain of the team. I'm gonna claim it. The reason why, it's because we see the patients more than the medical doctors. Another reason is we look in the mouth, and most risk factors are actually head and neck, right? Nose of the bridge to the Adam's apple. That's your upper airway. So we see all those, we look into those things. So being a dentist is really important. So that's my goal in the Philippines. I've been going to the Philippines and making sure that the dentists are on board on this one. Because if there's 900 million, I bet probably like 50% of their patients probably suffer from it, probably more. And if you are not seeing them, we're doing a disservice for our patients. Okay? So this is the part where I need to get a picture, because they want me to show a proof that I talk about this. Okay, so if you are wanting to chase this, there are actually good programs out there, and one is in August. Dr. Stanley Liu, this is like ENTs, doctors, myofunctional therapists, and dentists. Okay, so, and then there's one in November. This is going to be in San Francisco. This one is in Melbourne. Okay, so that would be a good start. Just get to know how the community work together, right? Healthcare professionals. Now, if you want a copy of the PDF, nagmamakawa, give me a follow. I'm just starting my social media. I'm not really that active, but I might. But I will give you a copy of the PDF files for this. Okay? And thank you so much.